I'm gonna keep on dancing at the Pink Pony Club. Now live on your YouTube channel. Dun, 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 dun. Pink Pony Club. Oh, we have 14 viewers here. Let's see what's going on. Hello, friends. Let's see here. Oh, I should turn the... Oh, the camera's not on yet. Do you have the camera on?
No, your camera's on.
I don't see anything. I mean, I see this portion of it, but I don't see it on Facebook. It still says welcome. Oh, come on, producer.
You're live on Facebook, buddy.
Sorry, friends. My producers.
This is Facebook Live, right?
Oh.
This
It's lagging.
Yeah.
Well, there we go. Hello, friends. All right. So it's a little bit lagged. That's what it is. All right. Let's see what friends have joined us. Let's see here. We're going to put this out there. Something went wrong. Pop out. We're going to see who's hanging out with us today. Ah, we have friends. Hello, friends. Ah, yes. Carolyn has identified the song as Pink Pony Club. That is correct. So we'll wait till some more people come on board so they understand why I would be singing Pink Pony Club. The most important thing is that I think she moves from Tennessee to Santa Monica, right? I think that's how it works. Isn't that true, Carolyn, that song? Let's see here. Insights. Here we go. Pop this out. Alrighty. We have 28 viewers here. We have 2 reactions.
Do you want them in person or Zoom?
In person, yeah, for sure.
Doesn't matter.
No, either way. Whatever's easier for them, yeah.
Any more chairs in here?
No.
Are people coming in person?
No.
For
For
next week.
clinic next week, yeah, exactly. Thank you, friends. As you all know, my birthday is on Friday. I like to say it's not really even a national holiday. It's not really even an international holiday. It is more of a, what do we say? Galactic holiday. I mean, come on.
The holiday week.
It's
Holiday.
the most important holiday in the universe.
That's right. See, Will, that's why we keep him around. It's so fun. All righty here. Let's see. What else is going on with you, gang? Let's see here. Yep, Carolyn's here. Yep. Margine's here. Hello from Albuquerque. If anyone knows my NP at the hospital, her name is Jessica. She calls it Albucrazy.
I like that.
Yeah, because she's from Albuquerque, so she totally has cred. She has cred, yeah. And Robin, thank you very much. Robin just spent a couple weeks up here in Colorado. I wish it was for vacation, but it was not, right, Robin? She was not for a vacation. Donna's here. Hello from Alabama. Kim's here. Jilly Bean. One of these days, we should have these sessions in Hawaii. Mostly from Jill's house. I think that's what we should do. Yeah. Oh, Rebecca. Hello, my darling. South Carolina. Christy's here from Cleveland. We had a meteor hit here today. Wow. Does that mean God is just mad at Cleveland and Ohio? I mean, what is up with that? Holy cow, that's craziness. I literally just was showing them a crater in South Africa of a meteor that hit. Oh, hi, Teresa. Good to see you. Donna, good to see you. Thank you. Mount Juliet, Tennessee, not far. Sandy Goldade's here. Marcus here. Something like that, right, Carolyn? Exactly. Hi, Mandy. Hi. All right. Hello, Ann Dabs. Hello, Stephanie. Hello, Jeff. Hello, everybody. Oh, Northern Virginia. Eileen lives in Northern Virginia. Where do you live, Eileen? Do you live in Fairfax or something like that? I grew up in Maryland. Nancy. Good old Florida. It was like 95 degrees there today in Florida, probably.
Swampy.
Let's see. Nancy's here from Abilene, Texas. United Airlines at a direct flight to Denver. Well, that makes it easy. So come visit us. Yeah. James is here from the DC area, of course. Luz is here from Toronto. I'd love to have you. One of these days, I think Trump may just take Toronto and just bring it to the United States. We'll see. Might be in the plan. We'll see. We'll see. Diana, thank you. Diana from Texas. Tina's here. Tina Lance is here. Hello, Tina. Cindy's here from San Fran. I think it's from Fairfax. Oak Hill. Oak Hill. My brother lives in Oakton. In fact, yeah. Wow, it's 97 degrees in LA. Brutal. Judith's here. It was 45 in Tampa? Wow, really? Mark, it's 40 degrees in Florida? That seems kind of terrible. Oh, 80 degrees by Saturday. All right, that sounds good. Sandy's here from South Carolina. All right, so we've got a good gang here. We got 48 people. Do we wait another 30 seconds or what do we do? Where's Susan? Nancy, you know if Susan's coming on today or is it just us, you and me? And the gang and the team? Yeah, maybe it's 32 degrees in Alabama. Oh, hey Lee. We'll see, I guess. Okay, so have you all heard of the song Pink Pony Club? Anybody? No one? No takers? Nobody? Pink Pony Club? Okay, so let me tell you what it is. Have I told this story before
Not to me.
on here? No, about my whole why I'm learning all these songs.
A little bit. I think you told
Okay.
me.
I can't remember. Maybe I've told you all these songs before. Okay, I can't remember if I told you the story, but basically, so just so you all know, because since I take care of most of you, I don't have dementia, but trying to fight dementia is actually a really big deal. I think it's a big deal for everybody. And that's one of the reasons why C's is so important, right? In order to be healthy and strong, you got to sleep well, eat well, exercise, and have good spirits. But one of the exercises that I'm doing is, so as you all know, I play the piano and I can sing pretty well. And I wanted to learn a bunch of songs. So you could, some do Stuco, some people do, what's that, Wordle? I guess people do Wordle. And then some people learn Bible verses, the Bible's too long for me to memorize. So I decided what I was going to do. I was going to learn a bunch of songs. And so I learned a whole bunch of songs, and some of them are pretty long. And I didn't realize how many lyrics a lot of the songs really had. So this past weekend, I learned all the words to Hotel California. And there are actually a lot of words to it. And so it's kind of an exercise for me to continue to keep my mind sharp and strong, because to be totally honest, taking care of you guys has become a little too easy. Yeah, it's not a challenge anymore. So I'm just I guess I need to learn songs. Now, here's the interesting thing. Everyone's just kind of oh, yeah, I know that song, Rocket Man. But do you really, really know all the words to Rocket Man? So I learned all the words to Rocket Man, and a lot of the words are really terrible. It's they don't make any sense at all. And I was just oh, sorry, Elton John, I know you have to sing this all the time, but none of it makes sense, right? Mm-hmm. And because, who wants to raise their kids on Mars? No one wants to raise their kids.
It's just not the kind of place you raise your kids.
Yeah, it's cold. It's cold up there.
Cold
up there, right?
Right?
Exactly.
It's so cold, you guys.
That's what I say. Yeah. So it's a little strange. And so, for example, how many of you know all the words to the song I just learned?
Pink Pony Club.
No, I haven't learned the words to Pink Pony, but yeah, Hotel California. Right. It's actually a really long song. And how many of you actually know what a colita is? I'm going to challenge you to tell me what a colita is. Yeah. Oh, look, Teresa, I would pay very big bucks to hear you play and sing Pink Pony Club. A great fundraiser. Yes, we should do that. Oh, speaking of fundraisers, thank you for all of you. I still need to get on and thank everyone, but thank you for all of you who were part of or were able to donate to my fundraiser for the Healing Net Foundation for my birthday. It was actually wonderfully successful, and I really appreciate all of you. And I need to sit down and just start saying thank you to everyone. Maybe as a thank you note, I will actually sing Pink Pony Club for all of you. That will be my gift to you. Okay, so how about this? We'll get started. We'll talk for a little bit. I just want to make sure more people got on. That's all I was waiting for. So this mindless banter is truly just mindless banter. You don't even see this one. Margot's here. Look at Margot. Look at that like slightly frustrated face, like just get started and start talking already. You're not as funny as you think you are. Oh, wait. I don't think Brenda's on. I didn't see her log in. But look at the shirt I got for St. Patrick's Day. It's an emerald green shirt. Thank you, Brenda. But I had to wear it over my other green shirt, my Wicked shirt. So there you go. It's the only green shirt I had. Happy St. Patrick's Day, everybody. All right. Hi from the number 19 spot of the allergy capital of the U.S., Winston-Salem, North Carolina. Oh, Kathy Parker. But the good thing is you can drink all of your allergies through this cup. Look at this thing. All right. Well, should we get started? And then we'll take a little bit of a break. And then because we're going to celebrate because Eleanor got me a birthday cake. Okay. What are your thoughts on... Oh, that's a big one to start off with. What are your thoughts on CAR T immunotherapy and the lanreotide pill? I heard they are in clinical trials and early development. Okay, yes. The answer is yes. So CAR T, let me explain for a second. CAR T immunotherapy is actually it's very, very complicated. It's essentially a custom-made immune cell that's designed to go kill your cancer. It actually has quite some good results actually in blood cancers. And so they've been using it for, I think, like various leukemias and lymphomas and stuff like that. It has not been totally worked out and proven for solid tumors. So I'm very, very hopeful. It could be an amazing thing, but it is not ready for prime time yet. So we will find out very, very, very early development. And even if it does work, it might be atrociously expensive. So it's not so great. Now, the lanreotide pill, it's actually not lanreotide. So what it is, it's a somatostatin analog, but it comes in oral form. So, the shot that you guys get is the hormone, right? So it's what we call a somatostatin analog, either octreotide or lanreotide. But, but it's a shot, right? So it's a pain in the butt, literally. Right? I mean, look at this thing. This thing's gigantic, this thing. And then... But they're developing, so this company called Crinetics is developing an oral version of it. It's actually not the same. It's a little bit different, obviously, because you can eat it, but you take it every day. I'm very, very hopeful. I'm super excited. I don't know if it's going to cure cancer by any means, but certainly if you could get a daily dose of it and it's much more consistent, I would be very, 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 very excited about it. So I'm excited. I'm hopeful. I think it'll be great. It's a huge advance. We've only been talking about it for 35 years or whatever it's been. So I really give the company Crinetics a lot of credit. We really do appreciate all that they're doing. So, but the question is actually deeper than that, because really the question is, what are the new and exciting things that are coming through with neuroendocrine? And that's kind of, it's so great because, for probably 100 years, no one even knew what neuroendocrine was. And now all of a sudden, all these companies are starting to develop things, which is super exciting. It's actually great for the Healing Net Foundation, because now we have more people to work with, more people in the community. And it's coming at a good time because more people are getting neuroendocrine, right? That is a fact. More people are getting it. I mean, Eleanor and I see it all the time, all these new patients. And I mean, really, if we could, we wish we could see every single patient for realsies. But it's becoming worse. So to have more tools and to have more companies in the mix is fantastic. We love it. We love it. We love it. Next question. Can a pancreatic neuroendocrine tumor still be called pancreatic cancer, particularly if you state it's one of two types? Well, that's an interesting question. So calling it depends on what you want to accomplish. So yes, of course, it is a pancreas. It's a cancer that originates from the pancreas. So that is 100% true. But generally, when you talk about pancreatic cancer, you're talking about what we call ductal adenocarcinoma of the pancreas. And so that's the nasty one. My grandmother died of pancreas cancer, and it was horrible. It was horrible. Neuroendocrine obviously is very livable and survivable and thrivable. So it depends on what you want to accomplish and what you're trying to do. So certainly you can say that, but it's hard. So for example, the Pancreas Cancer Action Network, I think it's what's called PanCan. I can't remember exactly what it stands for, but they claim to have claim on pancreatic neuroendocrine but they're not really very active in our community. So it goes a little bit both ways. Yeah. Next slide. Next question. Do you ever start chemotherapy after embolization of the liver tumor to prevent it from spreading elsewhere? Well, that's interesting. We talked about that pretty much all day today at our tumor board. Yeah. We have this really brilliant, which we love, tumor board, which is just a meeting really, in which we get all the gang together to talk about the cases. And so Ellen and I are, and actually all of us, the whole team here we're pretty fortunate in that we can actually mostly manage almost everything by ourselves, but we can't, right? It's a team effort. And so many of you have met Dr. Nutting or Dr. McMurray, our colleagues. And so we sat around today at lunchtime. All I got to eat was a Rice Krispie treat. That's all I got to eat. Yeah, for lunch. Terrible.
Pasta was
Yeah.
good.
Next time I'd like for you to do the presentations so I can eat. Really? And we talked about this, and we talked about how do you combine, because liver embolization is good, the drugs are good, but could they work even better together? And that was really the question. So the answer to your question, do you start chemotherapy after embolization, is actually not really what we do. We actually start before. So we actually start the chemotherapy, and kind of depends on dealer's choice and how you feel about it, in order to try to enhance the effect of the embolization. So we may start with a medicine that works, obviously, and then to see if the embolization, they can work together to make it better. And our dear friend, Dr. Solon from the University of Pennsylvania, did a very, very nice trial in his institution, in which he described the combination of the CAP-10 with the radioembolization, because both those drugs are believed to actually sensitize the tumors to the radiation. And he found wonderful results. And so, being a friend that I trust, we copied him right away. And so we're giving it a go. It's not perfect by any means. It's not perfect by any means, but it's something else to kind of build off of. So we like to do that, and we like to do it before the embolization. Oh, I see. That's not what the question is. I guess the question is, do you start it afterwards to prevent it from spreading? I guess so, but really we would just keep them on it. Yeah, I think really is how I would think about it. You can't stop it from spreading. Let's make this very clear. Neuroendocrine is a microscopic disease. It is already spread. It is done. If you have it in your liver, you need embolization. Don't fool yourself. The deed is already done. Cat's out of the bag, horse out of the barn. You guys have heard me say this before, and clearly I need a haircut. Margot told me I needed a haircut, and she was 100% correct. So if it's already spread everywhere, you can't stop it. It's just a matter of how fast and when and where is it going to grow. So that is just one thing you have to understand. We can talk about that more another time. Okay, number 4. I had a 9.2 centimeter pheochromocytoma removed in 2016. In September of 2025, it had spread to both lungs. Tumors are secreting per blood work. I was told it's inoperable, but on a watch and wait. Would you watch and wait or treat? Wow, that's a really interesting question. So just to back up for a second, a pheochromocytoma is an unusual and relatively rare tumor that comes from the adrenal gland. It frequently secretes hormones like epinephrine, so adrenaline, right? So what we call catecholamines is the fancy word for it. And it can make people feel quite terrible. They can be very hypertensive. They can have terrible headaches. It can be pretty brutal. And when it gets to be so large, 9.2 centimeters is pretty big, right? It's like these two things. So it's a pretty big size thing. So the fact that it was removed in 2016 is great. Now, the fact that it's come back in 2025 is a little odd, to be totally honest. It's not impossible, but a little odd. And so the question really becomes, is how closely were you followed over the past 9 years? Did it actually show up back then? Has it been growing very, very slowly? Because you need to know the pace of the disease, right? So you've heard me say this before, like I need to know the personality of your tumors and your disease. And so if your disease is growing at 3 miles per hour, I'm not so worried about it. But if it's growing at 75 miles an hour, and it's not growing 75 miles an hour, but if it's growing fast, then you have to be very thoughtful about it. The fact that it's inoperable is, I don't know, right? Because it depends. The watch and wait thing is impossible for me to know. So like I have very, very dear friends who are very into pheo-para, as we call them, Dr. Del Rivero at the NIH, and Dr. Fan at Milwaukee, they do a lot of these things, and they tend to be a little bit more aggressive, and there are therapies for it. The most important thing is that you see an expert. That's just kind of how I feel about it. And I know I feel like a stupid broken record all the time. Go see a net specialist. Go see a net specialist. Go see a net specialist. You guys have seen me do this all the time. But I feel very strongly about it. I think Eleanor has now seen it with our own eyes, how important it is to see a net specialist because we think about it very differently. And here's the more difficult portion of it. The more difficult part is you can go see a net specialist and you can still get a bunch of different opinions. And so you're going to have to kind of figure out who you trust, how you feel about things, and because none of us agree. And I can tell you that for a fact, because just last Monday, last week, we had a virtual tumor board. So what Carolyn Faulkner and the Healing Net Foundation, we do is we run a meeting. It's international, actually. We had one European doctor come on, and we talked about these things. And I heard multiple people disagree. Yeah, and these are like the most famous doctors in the whole wide world on neuroendocrine. And it just shows you that there are multiple ways to skin a cat, and people just have different priorities and different expertise. So that's what becomes so challenging for you. Obviously, I'm the one that was right. I mean, obviously, but I mean, yeah, it's my birthday, so just give it to me. Yeah, just give it to me. Yeah, give it to me. Next one. Yeah, James, it is big. It is big. There's no question. Is dip neck regularly treated with injections, or only if there was a malignant tumor symptoms? Okay, so that's a very interesting question to understand. So dip neck is a disease called diffuse idiopathic pulmonary neuroendocrine hyperplasia. It is not really a cancer. I have never seen it really spread except just a little bit. But what it is so diffuse means spread out. Idiopathic means we have no idea where it came from. Pulmonary means it's in the lungs. Neuroendocrines, obviously. And hyperplasia means growths, like little growths. So I think of them more like the dots on my arm than I think of them as a cancer, right? So for whatever reason, I cannot tell you why, that's why it's idiopathic. The little cells that control your coughing and your breathing and air movement and airway opening and closing, which are neuroendocrine cells, they control those things. They just grow for some reason. And they can grow some big, to be like this big, and some can grow small and just stay there, or they can slowly grow at 2 miles per hour for the rest of your life. Most of the time, it doesn't spread very far. So it doesn't go to your brain, it doesn't go to your liver, it doesn't go to your bones, but they just kind of slowly grow. And so the question really becomes, well, do you need to treat it? So I actually generally don't treat it unless the patient is symptomatic. And if the patient is symptomatic, actually the shots really work quite well. So the lanreotide or the octreotide are very, very good options. In general, dip neck is not a malignant issue. It is not like an aggressive, angry cancer like we have to deal with normally. And so I don't usually treat it unless there's some reason to, because it doesn't seem to stop the growth anyway. So that's why I just don't do it. So I only want to do it if it helps the person and if it makes them feel better. I mean, we had that scenario. In fact, one of my former PAs, great guy, he's wonderful. His actually mother-in-law had this issue. And so we treated her, and she lived, she was older when I met her, but she lived another like 12 years, feeling great. And so it was huge. It was fantastic. Yeah. So, but again, you need to be familiar with the disease to understand when and how and when it's appropriate, because there are side effects to all these drugs as well, too. So that's where you have to balance that, the risk-benefit ratio. Next question. Is it possible to have GI nets that do not show up on scans? Oh, yeah, absolutely. So is it possible to have digestive neuroendocrine tumors that just don't show up? It is possible. They can be hard to find. Generally, most of the neuroendocrine tumors show up on dotatate scan, but you may not get a dotatate scan if it's, if your doctor doesn't order it for you. So I cannot tell you for sure, but generally, I will tell you this. There's a hint of something. And so when someone's a true neuroendocrine specialist, he or she should be able to pick out, oh, that's a little strange, that's a little funky, and then dig deeper and then find it. There's no question that we can do a dotatate scan. You can find one tumor. Will and I will go do surgery, and we'll find 7, right? So there's no question about that. The most effective tool are these eyes and these fingers. There's no question about that. But usually there's a hint. There's a hint of something, and that's where you have to go digging deeper. But yeah, they may not show up well because they're too small, or they don't have a receptor, or whatever else is going on. This is where the nuances of all the things. In fact, I was just thinking about this because I was talking to Carolyn over the weekend, and I finished up this whole agenda for our big summit meeting that we're having next month, where we're getting all these experts together to talk about it. And as you guys have all told me, it's really important. But actually, as I've told you, you got to see a net specialist. And as you've told me, how do I find a net specialist? So HNF is really going to take this on and try to train net specialists for you guys. And I'm going to try to be a part of that training process. But it was really fascinating because I wrote down, you need to understand all the scans. I think Eleanor has seen it now. But unfortunately, most docs don't even look at their own scans. Yeah, it's a real problem. So there you go. Next question. Can an atypical neuroendocrine tumor be positive for calcitonin? Does it mean that is a metastasis of medullary thyroid cancer? What is the path to take or atypical neuroendocrine tumor with positive calcitonin? Well, that's very, very specific. So just so you know, calcitonin is a hormone that we make in order to control calcium, right? So what happens is if you take your body will naturally make a hormone called parathyroid hormone, and it raises your calcium. And then it has another one that's called calcitonin that lowers your calcium because it forces the calcium into your bones. Now, a neuroendocrine tumor of, I assume the lung is what I'm guessing. It's not clear here, but I'm assuming it's a lung, is stained positive for calcitonin, or it comes from the blood. Right now, you see how the details really kind of matter. So I'm not exactly sure. So could it be a medullary thyroid cancer, which is where it naturally comes from? It comes from the C cells of the thyroid. The answer is yes. All of it is possible. But the problem is I cannot answer any of these questions for you because I have not studied your case, right? I haven't seen your scans. I don't know what your hormones are. I don't know where they came from. I know your history. So I cannot tell you what that path is. So that's where you have to see a neuroendocrine specialist who can really answer the questions for you and really study your case. So people ask me this all the time on Facebook. Can you just tell me what to do? I was like, oh, I can certainly tell you what to do, but it is not fair if I don't spend the time and quality time to study your case, talk to you, figure things out so I can help you in the best way, right? I mean, it's not rocket science. So I don't know. The answer is maybe. And the answer is always maybe. Next slide. Number 8, do you see net cancer patients fare better with this neuroendocrine tumors when following a clean, natural lifestyle alongside medical cancer treatment? Yes.
Yes, yeah.
Versus those that do not follow any healthy anti-cancer diets? Well, that's an interesting question. We have this big, huge cake here, which is probably I'm going to say it's anti-cancer.
You should also
Yeah.
have good spirits. And
Yeah, there's the cake right there. There's the cake right there. So the answer is absolutely. I feel very, very strongly about that. And that really, whoever planted this question is great.
Yeah.
Because again, it goes back to C's, right? You have to sleep well, eat well, exercise well, and have good spirits. Those are the things. So having a clean, natural lifestyle is great because if you don't have a clean, natural lifestyle, you'll end up like that. Oh, good. Look at that. Ooh. Could you imagine? But everyone should do that. Everyone should eat good, healthy foods. Everyone should exercise. Everyone should, try to get the chemicals out of the food. Ultra processed foods are like the big topic nowadays, right? I mean, who knows what stuff is if they have to put there to ship their foods from Peru or wherever they come from. I mean, it's craziness. I try to cook a fair amount. My wife and I try to cook a fair amount for our family so that we at least know that the food. I started baking a lot of bread. I started making my own pasta with organic pasta. Yeah, I mean, I try. I don't drink. I don't take drugs normally. Thank you for that. I just needed a little bit. Come on, people, just a little bit.
You're doing great today.
Thank you, friend. Thank you. Sometimes you just need an audience here. This is why they're here. Actually, none of these people work for me, and none of these people know anything about neuroendocrine. They just are here.
I'm literally doing free labor for you. Free
producer.
labor. I'm not getting paid for this.
Oh yeah, and you'll never get paid for this. By the way.
I know.
Yeah, you'll get paid the exact same salary I get paid for doing this. How about So the answer is yes. The problem with an anti-cancer diet is I don't really know what an anti-cancer diet is, right? I mean, does that mean you're going to start eating lots of cinnamon and turmeric and between your ivermectin pills? I don't know. I would rather you just eat a lot of good foods and with fresh things with a lot of colors in it, blue, red, orange, green, the rainbow diet, because those are the things that Mother Nature created for us, right? And admittedly, they've been terribly mutated by mankind and by farmers and things like that, and GMOs and who knows whatever else that they've done. But really, the problem is pesticides and chemicals and stuff like that. And so that's really the thing. So do I know if organic is better? I don't really know. Do I hope it's better? Absolutely. Next question. What makes a determination between surgery to remove tumors in places like the liver and pelvis versus a treatment like PRT? Well, that's impossible for me to answer because it is from person to person. But this is what I would tell you. PRT only lasts a certain period of time. It doesn't last that long. And that's what bothers me. And there are a lot of toxicities to it. Surgery, I know it sounds crazy, but you can do it over and over again. And you take the tumor and you put it in the garbage can. PRT, you always leave the tumor inside there, and it will always grow through the PRT every single time. But if I take this tumor out of you, right, pull it out, and it's in the garbage can, this tumor will never grow back. Yes, the other ones will grow back. So it doesn't mean that, not grow back, but will grow. But it doesn't mean you don't have a little bit of both. And in general, I like to do surgery for big tumors. I don't think PRT works awesomely for big tumors. It seems to work a little better for smaller tumors. So that's kind of how I approach it. Next question. Oh, this is interesting. Patient lives in a 1-bedroom, 1-bathroom apartment. What does one do when they are getting PRT but live in a very small space with no ability to separate from family or pets? Well, that's fascinating. Mm-hmm. Here's what I would say. I'm not worried about the pets. Actually, the pets are really pretty resilient to it. These are all precautions. And I'm not saying it's not important, right? The most important thing is that the radiation, so when you do PRP, it's injectable radiation. Most of it comes out of your urine. So you got to really, really be careful. So really you want to just urinate in the toilet. And, if you're a man, you want to sit down for it so it doesn't splash. That's really the thing. And you do have to be careful. And there are thoughts. So maybe do the other family members maybe need to stay with other people for a little while. It's not that they can't be with you. Like, if I had PRT and Eleanor, sure, she'd be fine. It doesn't travel that far, right? As long as I don't urinate on her. And I haven't done that so far.
Today.
Yeah, not today.
Never at the office.
Never at the office. Yeah. So I'm being silly a little bit, but there's truth to that because it almost all comes out of the urine. So just being proximity is not really that bad. And if you can, even if you had to stay in a hotel for maybe 3 days, that could be an option as well. Or if the family, the pets, again, I'm not too worried about the pets because they're not going to use your bathroom. I assume, right? I mean, my dog is well trained, but not that well trained. Yeah. So that's really the thing.
The primary portion of the question that I had to edit out because of length was mostly just a financial problem with and constraint. And why that financial constraint would be a potential block against PRT.
Yeah, it's not impossible, but it's a precaution. It's really just a precaution. So if you had to bend the rules a little bit, just don't tell me about it, basically. Yeah, but just it's the urine that's the big deal. That is actually a big deal. The urine's a big deal. Yeah. Next question. When considering a bland embolization of 2 liver tumors which are growing in spite of Lanreotide in stage 4, more than 50 liver tumors, is it necessary to find an IR doc? Well, I always feel, the question really here is, if you're going to do a bland embolization, should you find an expert? I think is really what the question is. I always feel better about having an expert to do these things, right? So again, even just today, we have the blessing to work with people like a Dr. Nutting or Dr. McMurray, who are very, very experienced with these things. And even then we push them, right? Yeah. We push them today. So my feeling is, yes, you should find a good IR doc. You should find an expert IR doc if you possibly can. If it's just 2 tumors that are growing, then maybe you might be better off just removing them. In fact, that's what we did yesterday, right? There were some other tumors, but just you got to remove the ones that are misbehaving. So you've heard me say this before, tumors are a little bit like our children, right? So if you walk into a kindergarten class, you can have maybe a couple of kids who are terribly misbehaved, but the rest of them may be angels. And that can happen with your tumors too. So I think of tumors.
So ablate them.
Ablate the children. So really what it is you have to think of each individual, like you like the whole person as an individual, then you got to think of each of your tumors as individuals too. So it does require a lot of analysis. This is why I can't just do things willy-nilly over the internet, because I've got to figure things out, right? So let's see. Yeah, James, 8 bland embolizations. Yeah, 2 intracanal. Yeah, it's true. That's how it goes, James. Yeah, next slide. Or next question, sorry. If you have significant shrinkage from PRT, can damaged cells show a higher Ki67, or can it cause tumors to show hot spots? What does that mean? Okay, so you have significant shrinkage. That's great. Does it damage the cells and show a higher? Okay, I think I understand. So if you treat with PRT, can it make your disease run wild? I think is kind of what the question is. And does it like kill the easy stuff and then make the nasty stuff go up? So it's actually a very interesting question, because that happens with chemo all the time. If you treat people with chemo, it's not uncommon for you to kill a certain population of cells and then the other population goes crazy. We've seen that before. PRT is probably not really like that. What it is, they're all treated and they're all treated relatively equally, but then the problem is the radiation wears off and then the cells that were there just start to perk up again. So it's not that it can necessarily show hotspots. I've seen that before. Actually, I've seen that. Like one time we treated a lady like 10 or 12 times at PRT because I had no choice. It was the only thing that could control her pain. And then it ran wild. And then the ones that ran wild did not have any receptor on it. So I've seen it before, and it's not pretty. It really, really is not pretty. Yeah. All right. How often do NETs appear in the brain as the primary location? Where is it likely to metastasize after the brain? So it is nearly impossible for it to come from the brain itself. Okay. So meningiomas and other meningio types of things, so the lining of the brain, does have neuroendocrine receptors on it. It's not really a neuroendocrine cell. There are no neuroendocrine cells in the brain. But what it can happen, except for the pituitary gland, but what can happen is it can spread to the brain. So classically it comes from the lungs or from very high grade small cell neuroendocrine carcinoma. So that's where it usually happens. But after the brain, it can go anywhere. Once it's in the brain, you just have to assume it's going to go to the liver, the bones, and any place else. But most of the time it comes from the lung, most of the time. Next question. Wow, we are crushing this thing. Look at this. Flying through these questions. Oh, by the way, and if you have questions you want me to answer, make sure you just save it for the end, because I'm not looking at the other screen when I'm answering your questions. So just keep that in mind. Can someone get more than 120 milligram injection of lanreotide every 28 days? So let me answer it real quick. So in general, I don't usually do 2 injections of lanreotide. I don't think it works very well. What I would much prefer, because lanreotide is a little bit easier to technically give the shot. If anything, I will shorten the period of time between them. Yes, it's a pain, literally a pain in the butt to get more shots, but I think it works better because it depends on your symptoms. They have done some tests looking at 2 shots, and it is stronger, there's no question, but there are more side effects as well, too. Also, should MRIs be done instead of CT scans, or should they be alternated? Well, it depends on what you're trying to do. Right, so an MRI is really, really good for bones, really, really good for liver if the MRI machine is done right and it's beautiful. The CT scan is it makes a bunch of mistakes in the liver, so I don't love it. But if you are looking at the bowel or the lung or whatever, so you have to know what it is you're looking for. And you should mix in a PET scan every now and then as well. So it all depends on what you want to do. It all depends on how fast the disease is growing. It's about the pace. It's about the location. It's about all these things. This is why it's so critical to see a neuroendocrine specialist. And even the neuroendocrine specialists disagree about these things. But again,
You're always right.
oh, I'm sorry. My hearing is not good today.
You're always right.
Oh, okay.
It doesn't matter. We didn't put in a banner. It's not in a banner.
It's not a banner. Yeah, it's okay. Don't worry about it. Yeah, it's okay. All right. How about this? I just feel strongly about the way we do things. Is that fair? I think that's fair. Yeah. I'm certainly not smarter than everybody else. It's my wife will remind me. Number 15. I have read that using 150 watt microwave ablation in conjunction with an angio suite, they are having success treating livers in the 6 to 7 centimeter region. What are your thoughts on microwave? Okay, so let me make just a quick diversion. Okay, quick diversion. So I just learned the song Money for Nothing on the piano, and talk about lyrics that are really, really crazy. because we got to install these microwave ovens. Custom Kitchen Delivery. Yeah, that is a crazy song. Anyone know that song? Please
Yeah.
tell me you know Dire Straits. Please, please, please. So the answer to the question is using a 150-watt microwave ablation in conjunction with microwave. So let me back up a little bit. So what the question is asking me is basically there are different techniques for doing ablative therapies in the liver. You can stick a needle in there and just burn it with what we call radio frequency ablation. You can put it inside there, you can freeze it, or you can just put a microwave needle into it. So it's called microwave ablation, and it just burns it. That's what it does. It cooks it, it cooks it, it cooks it. So in general, I don't like to do that, okay? Because I don't think it's effective. I don't think the heat distribution is accurate. I don't think it's equal, and I think the recurrence is really pretty terrible. I did this yesterday. I mean, whatever it was. I didn't put it to 150 because I don't think it works very well. So we put sometimes we will put to 120. No, let's see, 60, 80, 1. Yeah, sometimes we'll put to 120, but I don't usually go to 150. If it's 7 centimeters, you just cut the thing out, right? I mean, that's like the wrong thing to do. You're much better off just taking this thing and just removing it and putting it in the garbage can. I mean, that's how I feel about it. I think the problem is that happens when people don't know how to do that. So then they do the microwave because it's all they know how to do. But when you have a command over all the techniques, then you can really decide what's best for the patient rather than just using whatever you have. I mean, if that's all you have, you can't travel, or that's fine. It's fine. I just personally don't love it. I'm getting all like verklempt. Oh, 16, please. I mean, next question, please. What is the likelihood that a typical grade 1 lung neuroendocrine tumor will metastasize? And if they do, where are they most likely to metastasize to? So I cannot answer that question because it's been very difficult to figure out. So if you have a small neuroendocrine tumor, it is true. It might be just a little growth. We call them little adenomas. And
Hi there. It's currently 5:45 p.m.
Oh, thank you, Siri, or whatever you are. It's 5:45. I don't know. Because they're different. And so what you always want to do is and the reason I don't know, to be totally accurate, is because the data from the past are really quite terrible. Okay, let me make this very clear. Before we had PET dotatate and all the ways that we have of kind of figuring things out, they would describe these things and say, okay, there's a 50% chance for it to be local for a lung neuroendocrine tumor, about a 25% chance for it to be locally metastatic, and about a 25% chance for it to be metastatic. Except I don't believe any of that anymore, because when I first developed the dotatate scan, I saw all these things that no one described, all these things. And so that's when I realized there's a before dotatate and after dotatate, and that made a huge difference. And I just think the workup was wrong, just wrong. Now that we are much more effective at it and much more kind of, it's a much more universal kind of way of evaluating patients, I do think that we are getting a better handle on it, but now I don't really know because all that's changed. But generally what I would say is I cannot tell you how likely this metastasize. What you need to do is you need to look up front and evaluate it and find out if it has metastasized. That is what you have to do. Probabilities don't mean anything for any individual person. But if you don't do your homework, if you don't measure twice and cut once, you will always have a problem. Next question. Are there any studies on menopause hormone changes in neck tumors, specifically lungs and dip neck? Not that I know of. I could be wrong. So if anyone knows of anything that I don't know, please let me know. But in general, the menopause hormone changes don't usually cause changes in the growth of the tumors in the lung. They can change the way you feel. There's no question about that. The breathing, the emotional, the hot flashes, the brain fog, all those things are very real. Don't get me wrong. I mean, sometimes I feel like I'm going through menopause. There are sometimes I feel like that. You know? Oh, well, hey, I'm getting older. We know that, yeah. But in general, it does not seem to affect the lungs and dip neck in general. Yeah. Next question. Can hormone replacement therapy or hormonal cream be detrimental to NETs? That's a really interesting question. So, HRT therapy is actually pretty good. It makes people feel a lot better. So taking a tiny little bit of testosterone or a tiny little bit of estrogen can be helpful. I have seen with my own two eyes, if you take excessive testosterone, it can make the disease run wild. But that's like people who take very high doses, like, rubbing all over the body. And that is not healthy. That's not healthy. You probably shouldn't do that at all. I've never seen a woman take HRT because usually it's very, very, very low levels just to kind of get rid of the hot flashes and kind of help their mind a little bit. I've personally never seen it. What I can tell you is the receptors exist inside the cells. But usually if you're taking someone who's like below normal and bringing them back to normal, they're usually pretty okay because the tumors lived in a normal environment anyway. We have seen many, many young women get pregnant, have beautiful babies, and their disease is still very quiet and very, very manageable. So I cannot really ever answer that question. I'm not sure we'll ever be able to answer that question. But in general, in my experience, and no more than that, it's been okay as long as you're careful about it. Careful. 19, get in there. Can a lesion on the liver that lit up on a DOTA scan but comes back negative for cancer on a biopsy still be cancerous? Well, that's an interesting question because the devil is truly in the details. Lit up is an extremely relative term. And I think Eleanor and actually the whole gang has seen all this now. It takes a careful, judicious eye who understands the disease, understands the scan, understands how to analyze it, how to manipulate the pictures to really know what's going on. So the answer is absolutely. It can totally come up, quote unquote, lit up on DOTA scan, and then come back negative for cancer. Why? Because they missed it. Because they missed it. Yeah. I'm not saying they did, but it can. So can it still be cancerous? Maybe, possibly, depending on how much it's lit up and whether they did a good job biopsying and how difficult was it to biopsy. So all the details really, really matter. So I cannot tell you for sure. But yeah, anything can happen. 20, is it possible to have metastases completely removed from the spine and other bones? Well, that's an interesting question. So the answer is usually not. Usually not. So when people have disease that spreads to their spine and bones, there's usually a bunch of them. That may not be the case. We definitely have people who have solitary one-offs here and there. And usually, actually, I don't do much about it because it doesn't hurt the patient because we're dealing with their liver or something else. But if they have it and it's causing them problems, then we are very open to putting needles into them and burning them and killing them and putting some cement in there to shore up the bones. So the answer, is it possible? For sure. Is it common? Probably not. And it depends on the scenario and what's going on. That's it. 20 questions.
That's good. Can I ask a follow-up question?
Of course.
Can you tell me what happened with the patient, the one patient where you saw the cells go crazy with PRT quieting down the other ones?
Say it.
The PRT that responded with like exploding disease
Yeah.
after your 12th round.
Oh,
How
okay.
did you go in and control the other ones that were exploding? Or were you able to?
We were not able to.
Okay.
Yeah, so we tried to
the
give, we tried to give her medicines, we tried to give her stuff. Disease ran wild.
And there was no way to bring it back.
I couldn't. I gave her everything. Yeah, she passed away. She died. Oh, thanks.
Ouch.
But we're gonna turn all that around because my birthday's on Friday. And so we are going to share birthday cake. Who here wants birthday cake? Anybody?
Pork?
All right, actually, now we have some questions. So while you get that, let's see if we can bring I do have to go soon. Okay, let's see if there are any questions. Oh, we have it's from Lima, Peru. We have a lot of friends from Lima who work here, actually. All right, let's see here. Oh, hi, Bonnie. Okay, let's see here. Let's see if there are any questions to answer. Kelly, is it likely to go to other places if the primary tumor was in the terminal aim with lymph nodes affected, although all removed from surgery? It is distinctly possible, Kelly. I just don't know. You just need to have a good full evaluation. I see Joanna says, oh yeah, Joanna, yeah, mom's in Poland, has bony mets from her lung neuroendocrine tumor. She is monthly on Zometa. That's fine. The last year she developed hives and her skin is burning. Could this be a side effect? Yeah, very, very reasonable. There are different types of bone medicine, so they may have to switch to something. Rebecca, interesting. What do you think about red? I assume that's red light therapy, Rebecca, for pain. I know your tummy has these issues. I think it's reasonable. It's always a risk-benefit ratio. So you want to see, I don't know if it'll work, but if it doesn't hurt you, I think it's certainly willing to try. And if it feels better, great. And if it doesn't feel better, okay, then you have to move on to the next one. Matisa, How would you diagnose spine metastases to the thoracic C6-7 area? Would a CT chest without contrast with 3D images probably be something you'd use? No, absolutely not. We would definitely use an MRI. No question. I would not use a CT personally. Jody wants to know, when people stop taking Cabo, is it most commonly because of toxicity or ineffectiveness? It's both. If it is due to toxicity, can it be restarted, and how many restarts can one person do? The answer is yes. You can do as many as you want, depending on totally how you feel. James, Dr. Liu, do you know any studies on the long-term impacts of neuroendocrine carcinoma syndrome on the brain as far as it's not related to brain damage or slowing the brain? So the answer is yes. I don't know about long-term. That's not so clear, but there's no question that carcinoma syndrome can cause people to feel a little bit funky. In general, we've not seen like long-term like injury and damage to the brain. But the problem is, since people live with the disease for so long, they continue to have these symptoms. So really, you gotta go for the disease. You gotta treat the disease. You gotta help people with the disease. Oh, really, Ann Dabbs? How many candles are on that cake? How about this? Fewer candles than your cake, Ann Dabbs. How about that? Oh, boom. All right, let's see here. Thank you for all the birthday wishes. Let's see. Deborah says, hi from King. Do you specialize in lung nets? I try my best to specialize in all neuroendocrine tumors and to help people as best I can. I don't do lung surgery. That's the only difference. I only do it in the belly or someplace else. Yeah. Let's see, Mimi, do you need an interventional radiologist with net expertise to do a liver embolization, or would any good IR can handle it? Well, I mean, that is hard for me to answer. Of course, any IR doc can handle it and do it, but I just think there's some special things to think about with neuroendocrine. Not everyone thinks that. It's just that we know it. We just know it, yeah. Stephanie, low ACTH but normal cortisol. Any thoughts? Stage 4 level metastases, too many to count. So if your cortisol is normal, then that means that it's purely symptomatic. So we got to figure out what's going on with you symptomatically to figure out what you need to do. A normal cortisol may be not normal for you. Yeah, so we got to figure that out, Stephanie. That's much more complicated. Sherry is correct. There are 52 candles on this, just as there are cards in a deck of cards. Joanna, Dr. Liu, a bit of a personal question. Do you get checked regularly? Do I get checked regularly? Like me? Yeah. I have my own personal nurse practitioner who checks me every single day. She checks me for mental health problems, which she checks me for, yeah. And regular scans and blood work, etc. As a caregiver to a mom who has had 3 primary cancers, I have a slight PTSD and I want to be proactive. Yeah, you should be, Joanna. I think that's a good idea. You should be proactive. I think a family history is not fake. You should do something. Oh, Christine, I'm so glad we can help you. Let's see, last month on elevated alkaline, I advocated hard in demand in ERCP, and there was a tumor found, carcinoma. Yeah, it's complicated. I'm not sure I can answer that for you right here. Mark, can a primary neuroendocrine be on the foramen of the sacrum? Yeah, for sure. That can definitely be, no question. Let's see, Eileen, is the clinical trial on oral somatostatin analog targeting stabilizing tumor as well as carcinoma? No, the trial, Eileen, is just for symptoms. Thanks, Dan. Thanks for the birthday. Let's see, Judith, can metastases present as ulcers in the small intestine? Not usually, but it can be. Not usually. What can happen is a tumor can start to secrete things that can cause problems. That can definitely happen. Denise Camacho. How are you, Denise? Long time no see. We miss you. Right? Don't you live in LA now? Let's see. Is it common for tumors to shrink with land retard? If yes, can they continue to keep shrinking? So generally, no. It is not common, Denise, for the tumors to shrink, but they can be stabilized. And in general, they don't continue to shrink. That's not the usual. That's why we have to do all these other things like surgery or embolizations or all the things. Denise used to come for her shots. And Dabs, that's why reset your clock. Maybe one of these days, Tennessee will win a championship for you. All right, friends, that is it. I feel very blessed to have you all here. It was great to see you all. I hope. Tell me that this is useful to you. Tell me this is helpful. It makes me feel better, and mostly because Eleanor, never says anything nice about me, so I need to hear it from you. And more importantly, the Healing Net Foundation is always doing stuff. And if you can go back to my birthday post and donate just a little something to the Healing That Foundation, we would really, really, really appreciate it. And we really need it. We have so many people here we have 4 people right here who are working hard every single day to help people with neuroendocrine tumors, and with even some other kinds of cancers too. But there's a lot that needs to be done. There are a lot of people who need help, and as we get out there and preach the gospel and tell people about that we're here and you will help another person. I'm hoping as Healing Net grows that we can have programs where doctors can share information. Maybe they can travel and spend time in other clinics. Maybe they can learn from each other. Maybe we can have this fellowship. Maybe we can standardize a lot of the therapy, so it's not just one opinion here and there, and how complicated it is. And even training more APPs and training more nurses and training the people who really take care of you is just so very important. And I know the healthcare system is becoming actually more broken down. I do know that, and it's becoming more frustrating. But it is so very important. And your support means a lot to all of us. All right, everyone, be well, be safe. We will enjoy this birthday cake with all of you, and just do all that you can to talk about neuroendocrine. Okay, I'll see you guys later. Bye, guys.